And so it's helping the tumor to, be slower in its progression pattern, the cancer be slower in its progression pattern, but it's sort of failing slowly, I guess you would say, but not failing completely.
The cancer medicine.
Yes, the cancer medicine. And I know you've had some, you've noticed some of these areas, like the nodularity near the prior,
Yeah.
scar.
Do you want to see it?
I can, yeah.
I mean, here's. So it's like right up here.
Yeah. Yeah, there. I mean, obviously not dramatic, super prominent, but something you can notice.
Does it show up in the scans as a?
There is some nodularity in there.
And then this is the one. This is the one in the lower back that's very sensitive.
This one definitely shows up. The area near the scar doesn't show up quite as well, honestly.
Yeah, that's the one that's real sensitive to the touch, like,
Mm-hmm.
you know, when I'm driving, I can
Yeah.
feel it pushing and stuff.
And so,
And I've got this, lump on my breast area. It's also pretty sensitive. Yeah.
that, okay.
Yeah. So do we feel these are sarcomas, or?
I think they are, yeah. At least the ones in the lower back looks very consistent. I mean, I'm a little bit less sure about the area near the scar. Could, small areas could be scar tissue, but I think these are most likely all the sarcoma. I think they're gradually, slowly getting worse in a slower pattern than would be if you were not on the cancer medicine. But still, when things are failing in a more slow pattern, it's always a question of, well, whether that's good enough to sort of just stay the course, or whether it's worth trying something different, to see if we can halt it more convincingly or cause them to regress. The other alternative would be to go back to IV chemotherapy and get off this medication, and to see if that would have more of a pronounced effect on, I guess, a more pronounced halting of the growth pattern that's happening.
So how is that better, or what's the difference, or?
Well, the medications work somewhat differently. The pills and the IV cancer treatments, they have different effectiveness on the tumors. It's a little bit hard to know which one's going to be more effective until you try it. Just the IV chemo. So I guess the other aspect of it, before we even get to that decision, also is I would say the fluid on the lung is another aspect of things too. And
so do you feel? I mean, this is where the big question is like, what's causing that from? I know I probably started from the pneumonia, but then it got worse, I guess, when I traveled.
I think that the pill itself, the cancer treatment, can contribute to that, if not cause it. And so I think that it's, at least in part, you might say, a side effect of being on that medication. It can affect people's vasculature. That's part of how it's supposed to work for tumor controls, to, cut off the blood supply to tumors so they don't grow as quickly. That's how these pills are supposed to work in their cancer treatment. But as a consequence of it, some of your normal vasculature is affected.
Okay, well, that's helpful information.
And so I think that it can cause, in some people, fluid leakage or buildup, and some people have it in, like swelling in their legs, for example, and some people can get fluid buildup in an area like the lung that's more sensitive because there's tumors in the area, or because you had a pneumonia, and so forth and so on.
Did it show any new tumors in my lungs? Because I know it had metastasized there, and that's why I had the surgeries.
It's clearly in the lungs. I mean, we've been tracking them since they showed up before we even started on the pill. And there's several areas that are, again, similar.
So even after I had the surgeries, there were
more showed up on the next scan after the surgery, yes. And so additional ones grew in the lung after that. Unfortunately, there's
I didn't know that.
That's
more growing in the lungs.
Yeah, that's the reason we went on the pill largely was because of already there was significant growth after the as soon as we took a new picture, and unfortunately
I'd have to listen to that video again.
Yeah, no,
yeah,
I mean
it's
okay. It was probably it was a pretty.
I know that they were coming back in some places.
Yeah.
I didn't remember.
So I think obviously we know that this tumor is. This cancer is almost a full body illness in your case. It's gone through the bloodstream and it's seeded all these areas, and there's even more than what we see on a scan. There's likely microscopic amounts in many places in the body that are too small to detect on a scan. And so even if we were able to go in and surgically remove everything we could see, it would not cure you of your cancer. There would still be more left that would grow in other areas. And so I think that we are going to be moving forward almost completely reliant on medical management to try to slow the process down through these various chemotherapy and chemotherapy-like things to try to control the growth rate of the tumor to the best that we can to extend your life as long as we can. That's the strategy of our current treatment. That's the best we have available right now with these types of tumors. The
So
pill has
would
done
would any of them need to be like removed, like before when I had them removed, or?
I think that there would be somewhat limited utility to going in and removing tumors right now,
Okay.
because I think it's more of a, more of a systemic problem, you might say, within the
I
whole
would just
system.
keep having surgeries to
I
remove
think
stuff.
so.
Okay.
I think surgery would be mostly limited to things that were, if there's a tumor that's causing a particular problem that we think could be fixed by surgery. For example, if there's one that is significantly painful and removing it might help remove the cause of the pain, that could be a consideration. For example, if we thought the surgery was, easy to recover from, et cetera, and low risk and so forth. And so things like that could be a consideration, but more for symptom management, not really for the goal of extending life and bigger picture. I think it's unlikely to have an effect on that, unfortunately.
Okay.
And so I think, as we somewhat have been, or I think every time we get a reassessment, it's always a little bit of a decision on how to proceed in terms of the continued management of this. And it's a bit of a judgment call, frankly, about how things are going with yours, because you do have some of these areas, like the ones you can notice, that have, as you notice, been gradually getting worse over months, right? So these areas
So,
of the
just
back,
3 months, because
they
didn't seem to be there in my January scans. So
Yeah, I mean, some of them are, to the point where they weren't detectable and are detectable now, right, on scans. And so things are getting worse, though at a rate that's a bit lower than they likely would have been had you not been on the medication. And so that's not a perfect result, but it's not, nothing either. And so sometimes, the question is whether that's good enough or whether it's time to make a change and try something else. Because the other alternatives are not perfect either. IV chemotherapy has its own set of issues. In terms of quality of life and coming in for treatments and all
if
that,
we did go that route,
and it has more of an unknown effect on how it's going to affect the tumors.
Mm.
If we were to go that route with the IV chemotherapy,
do both, right? I wouldn't keep on the chemo
you
pills.
wouldn't keep on the pills also.
Okay.
It's just a little too harsh on the body to do both.
Mm-hmm.
We would come off the pills and let your body kind of recover from that for a week or two, and then start on a IV chemotherapy regimen.
So was that the inpatient like it was before, or?
So actually, we wouldn't do the same one as before, because that one is we tend to cycle through different ones to try to treat differently, because if you keep going back to the same ones, they sometimes can have less of an effect as the tumor's been exposed to it.
Yeah.
And also that one, frankly, is a bit on the harder side too, in terms of how aggressive it is for the body and requires this inpatient part of it. Most of the ones we use are outpatient. In other words, you come in for an infusion and go home the same day after a few hours of getting hooked up to IVs and so forth.
Can that be done at IP?
And it can be done at International Plaza. And so I'm somewhat inclined to make a change actually in your treatment because of this worsening pattern, including things that we're seeing that you're noticing more. And also with this fluid accumulation issue in the lung that's continuing to be a problematic issue for you. If it is still in part related to the pills, then perhaps that can improve over time somewhat if we take that factor out of it. So I'm somewhat actually inclined to make a change back to the IV chemotherapy.
And that would be, what's the frequency?
So this we give every 3 weeks a dose of it. The one
Okay, well, that's not too bad then.
and so it affects you, for a large part of that time. It's like you feel it for a week and a half, and then there's recovery, and similar to before, there's.
So it's like one day for
cyclical.
several hours every 3 weeks.
Well, actually, the one that I would use is a little bit specific. So you would need a port.
Oh, another port.
Again, the drug that we use is called Rectin, and this one actually requires a 24-hour infusion, but they actually have a one that you go home with. It's almost like they hook you up to something after giving you some medication at that time, and it's like kind of infuses over 24 hours at home. And you come back the next day and get disconnected from it.
Okay, well, so I have to stay overnight. So
you don't have to stay in the hospital. You take it home with you, kind of.
Okay.
And so it's like a chemotherapy pump that is designed for this reason, clips to your belt or something. and then that's given once every 3 weeks.
So then it's 2 days basically. So I would go into IP.
Yeah, you go in and get
And
sort
then
of the,
go home and
you
then
know,
go back
the
the next
blood.
day.
So the day of the the first day of the treatment, you go in and get blood work done and sort of get cleared for therapy. A nurse practitioner sees you and checks your blood work and so forth, and then you get some pre-medications and then hooked up to this chemotherapy pump that you go home with, and then come back the next day just to get unhooked, kind of, or deattached and
Right.
take
Okay.
out the port and things. And so that's the way that this one functions. All these, all the chemotherapies are a little different, and some of them you get all the same day. Some, this one has this more
Yeah,
specific 24-hour infusion period that is designed for, and that's the one I think we should. It's enough of issues with both side effects and lack of effectiveness at Foley stopping that it's worth trying something else.
Sure.
And so I think that we should go back to this IV chemotherapy to see if we can better control it that way.
Okay. And so I'm supposed to see Dr. Toulouse on Tuesday, I think. And what are your thoughts on the Plerex catheter?
I think if it continues to be a recurrent issue, you definitely have the fluid there, and unfortunately, oftentimes when there's an issue with fluid like this, it has it reaccumulates over time if we don't take away the offending issue or treat the
so if I'm
underlying cancer.
going to stop
But since we're
the,
going to stop the pills, I'm almost a little bit inclined to see if
not
it's
do it.
if you don't need it necessarily, and see if it's able to resolve somewhat on its own, if that may be partially offending agent or reason for it. I might consider deferring it. It depends a little bit on how symptomatic you are from it, how much your breathing is affected, and whether you really need to have repeated drainages of that. If you keep every week having to come in to get that drained, it starts to make sense at some point to put in a drain that you could
Right.
do. But again, since we are making a change that may affect that, I think I might lean towards not doing that initially.
Okay. Well, that's good. I wasn't really looking forward to that. So.
Yeah,
And that's why, the pulmonologist wanted to do it right away. I'm like, well,
yeah.
I'm going into Moffitt, and
So how many times have you had that drained so far?
So I had it drained in February.
Yeah.
Is it February? March?
Mm-hmm.
No.
It was February. It was
It was February.
President's Day weekend.
Right. It
We
was
were in
before.
Chicago.
It was before my birthday. So, yeah. So I was here.
Mm-hmm.
I think it was February 22nd actually.
Mhm.
Now, and that's when they drained it the first time.
Mm-hmm.
And then I was supposed to go on vacation.
Mm-hmm.
I was supposed to fly to New Orleans, but I didn't fly. I drove.
Mm-hmm.
And I was fine, and I came back, and I could feel it was coming back,
Mm-hmm.
even though I didn't fly.
Mhm.
And so that's when I was trying to get in touch with you guys and the pulmonologist and figure out.
Yeah, where
to
the
do.
easiest, quickest to take care of it sort of
They
thing.
finally said I finally did have a chest X-ray, and it was. That's when I sent you the results. It was.
Yeah.
No, that was the follow-up one. Anyway, but they said it was I had an enlarged heart and I had a large amount of fluid.
Mm-hmm.
So they scheduled me for thoracentesis with their office, but it wasn't until Tuesday, and she said if it's really bothering you can go to the ER.
Mm-hmm.
So I went to the ER. I looked at my insurance, and they're like, doesn't matter, I'm 100% because I've already reached my deductible. So I went ahead to Dunedin Hospital, and they did a thoracentesis, but it was a lot more painful that time.
Mm-hmm.
And they took out more. They
Mhm.
took out 1,000 cc's.
Mm-hmm.
And I was having a bunch of coughing. They did some chest x-rays and discovered they had punctured the lung.
There's still some air in that area from where they had done
Yeah.
that.
So I had a trapped lung and a collapsed lung,
Mm-hmm.
and was in the hospital for 5 days.
I see, yeah.
So the chest tube.
So it's obviously a lot more complicated that time around, yeah.
Yeah, and so I'm still. They drained it
Yeah.
for 5 days and stuff, but it did come back, and
Yeah.
I just can't do a lot of normal activities
Yeah.
because I am short of breath, but I don't want to keep going back and having
Yeah.
thoracentesis either. So
Yeah, I think, there's still obviously fluid there, and I don't know if it's reaccumulated since then.
well,
or
the last
partly
chest
at
X-ray
least,
was moderate, so I guess
It's more moderate
maybe
now
what I
still.
should do is just
I think
have a
maybe-
chest X-ray once a week or
Yeah,
every 2 weeks or
oftentimes
something.
these things, whether they need a procedure or not, are based mostly on how much level of symptoms you have, and because it does tend to relieve some of the breathing symptoms to remove some of the fluid, as for obvious reasons, as it takes the pressure off. And whether it's how long that lasts though, because once the drainage is done, it does reaccumulate over time.
Is there anything else I can be doing to stop the flu? I mean,
I think again, stopping this chemotherapy pill might help, and that's another
that's really
reason
the only
to
thing.
do
Okay.
it. But other than that, there's nothing too much that I think you can.
There's
do
nothing else that's
physically,
really causing it. I mean,
I think that that it's mostly that, I think, and nothing that you're doing specifically. I think that's
Okay.
like physically or
Okay.
whatever that you can do. I don't think.
Okay.
So I think on that issue, since the level of symptoms you have currently is not severe.
It's not severe. I mean, it was more severe before, like, when I was struggling the second time, and
Yeah.
just like every time I would bend over to pick something up, I was coughing, and
Yeah.
I could feel a lot more. I mean, I feel it, but it's not.
I mean, it's
Other than being short of breath, I can function
yeah.
every day.
Since it's not severe right now, I'm sort of inclined to just see if it maybe can improve off the pills over some time.
Well,
And see if
I'm good with
maybe
that.
avoid having a tube sticking out.
Yeah,
And
I
avoid
really
having
don't want
another
that.
procedure.
Yeah.
Obviously, if
fine.
it's getting worse, it needs to be drained again, and it's now we're like third time, and it's already within a week, it feels like it needs to be drained again. Then that's when we start thinking about you needing the drain, and
Okay.
so I think maybe we'll just have to kind of do like a wait and see on that probably.
Okay, I'm good with that.
That's what I'm a little bit inclined for. So let's have you stop the pills sort of now.
Okay.
Give your body a break from it for one. Let's schedule to get a port put in.
Okay.
And then,
I have to come here for that.
yes.
So if I'm coming on Tuesday to see Dr. Tolosa, can
Mhm.
I just go ahead and have it done that day?
The port, I'll put in the request. I don't know about their availability. It's,
Okay.
through the interventional radiologist,
Right.
and, they'll review and call you to get scheduled for that.
Okay.
And then maybe in a couple of weeks, we'll schedule it for the first dose at the International Plaza.
All right.
Will that
Or,
new,
or was it,
Will
what,
that-
International's the closest one for you?
Yeah, it's half the distance. I live in
Yeah.
Clearwater.
Clearwater, okay, yeah.
will that new drug cause hair loss?
It will,
Oh no. Oh.
it will.
Oh. I'm so happy I got my hair back. Oh. Oh well.
Oh.
Damn.
It will, probably, yeah.
Oh well. I've had a year and a half of getting my beautiful hair back.
I know.
It's alright.
You can pull it off.
Uh.
You looked good the other way too.
Some people said that, yes. I didn't like it, but
Well,
yeah. If it keeps me alive, then it's okay.
all this is just trying to, keep fighting this thing off and, the
Yeah.
best that we can. And it's the best option we got. I think it's time to make a change. So unfortunately, it's back to the IV ones, which are, it's nice to be off that for a while, but I think this one is sort of, failing us a little bit in a couple of ways, and it's time to make a change. So
Yeah.
give you a little break, but then kind of get geared up for this over the next couple of weeks.
And so that would just be every 3 weeks, pretty much indefinitely.
Yeah, after we do a few of them, we'll do another scan, of course, and see how
Thanks.
things look, and decide how much of this to do. I would say it's a little bit of an open-ended how long we'd go for, and of course depends on how well it's working and how much it affects you.
Right.
From
What
the
are other side
standpoint.
effects of this particular chemo?
Well, all these chemos are fatiguing and have some degree of nausea or not feeling well.
Which
and
the other
hair
ones
loss.
didn't do that to me at all. So.
Some are, and they're all a little different than others in terms of how they feel, and blood counts being low, and monitoring things on the blood work and things. So those are the main things we look for most of our chemotherapies, and just have to kind of go see how it goes with each round and adjust if need be based on that. And hopefully it'll be, not a major quality of life issue, although there will be times where it is because it's really fatiguing or something, or just, bit out of it for a week sometimes, and but we'll have to see, and if it's pretty severe, we'll cut back, and if it's just kind of okay, it's tough, but I can get through it, then we'll stay with it and see how it works, and just kind of go dose by dose and decide on that.
And it's not really gonna shrink anything, it's just gonna stop, that's
Sometimes
right.
they can reduce in size when you treat them with these, and they can, you can see them regress. And so that would be the best, case scenario. Obviously, if we see them, not just halt in size, but kind of, reduce, that would be obviously a good sign. But we'll take even a halting of further progress too as sort of a good effect. And we'll have to, again, we'll kind of see, we'll reassess. Usually we give it 3 rounds, and that's a couple months, and then that's 9 weeks. So that'll be a good time
That'll be the
assessment.
next scan time about it
That'll be
anyway,
scan
so.
time, so we'll scan a little earlier just to make, than we would have
Right.
otherwise, just to make sure we're.
Do you have
in a
pictures
good
of my
trajectory.
scan?
I can show you some
Can
pictures of
show?
scan,
As far as clinical trial studies,
Mhm.
are there any really for sarcoma or not so much?
There are some, but not as many as the more common cancers.
Yeah, sarcoma
Um,
gets the short shift.
Just it's unfortunately part of the, but there are some, and there's a variety of them, so there's some that are focused on, any sarcoma, there's some that are gonna focus on a certain type of sarcoma. In addition to having a rare type of tumor sarcoma, you have one that's actually on the more rare side,
Right,
even
rare of
within
the
that.
rare, yeah,
And so there's none, to my knowledge, focused on actually your specific type of sarcoma.
right.
And so sometimes we do look for clinical trials, and generally, when I do that, I'm trying to find one that that allows any type of sarcoma on it. Or there's sometimes the other avenue that we sometimes look for are early phase trials that allow any type of cancer on, and those are generally phase 1 studies, meaning that they're the first time being testing a new drug, and sometimes those studies will allow any type of cancer because they're just kind of first testing a drug and even trying to make sure that it's safe, has some effect at the dose that they're looking at, and looking for any sort of signal on anything. And so sometimes those will allow any type of advanced cancer. And so early drug testing is another avenue that we sometimes look at.
But we're not quite there yet.
I'm a little bit inclined to look at one of the more, known chemotherapies that has a known effect, rather than doing that at this point. But I'm very open to looking at that idea. There's pros and cons to it, with these things and with the trials. Of course, it's, we're obviously a research center, and that's one of the main things we do. So we're sort of inclined to do that as much as possible to see if we can find new treatments for people when we don't have perfect ones. And so I think it's, philosophically, I'm very, in favor of trying to do those as much as possible. The downside is that, historically our success rate for finding new drugs in these early phase trials is pretty low. 5% of them maybe make it all the way through to really being a drug for people. And it's a lot more involved time-wise. There's a lot more, clinical visits required and monitoring blood work for obvious reasons. We're testing new things out and need to do a lot of testing, and so it's a lot more work required for the patient in terms of the amount of visits to Moffitt
Right.
and check-ins. So that's just a practical consideration also. And so I when to integrate those into the treatment schema, so to speak, is somewhat in the eye of the beholder a little bit, and to some degree based on your philosophy on things. I'm a little bit inclined to try this IV chemotherapy, but it's already kind of rising my mind to start looking even for early phase trials and thinking about that.
Okay. Is that something that she should be researching, and how do we go about that? Or is that something that you would research and say, I think we should try this next time, kind of thing?
Yeah,
or?
generally I'm trying to help advise people on that because it's a tough thing to navigate, obviously, and that's
Yeah.
I would.
I mean, early on, people research all this, and so I tried it. It's like, no, it's still not.
You certainly can
Not
research things
really.
on your own, and if you find things that are sort of like, hey, what is,
Yeah.
please feel free to ask me about it,
Yeah.
So I don't,
So let me
I
go
certainly
down.
encourage you to do your own research and be your own advocate. And
So let me go down the road of things that people keep back,
Yeah.
Like, I think we talked about immunotherapy. That's not really for
Mhm.
sarcomas, and
They haven't had a great success rate,
Right.
although that's something that I've also tried in sort of a semi-experimental way, not necessarily through a formal clinical trial, but through getting compassionate use for one of the drugs that's the most commonly used in cancer treatments and trying it out. I view that as a sort of, like I said, semi-experimental way for these two cancers as well. And
is immunotherapy something that you can do like with chemotherapy, or are they,
It's like
you
in
don't do them at the
replace.
same
It's like
time?
Usually,
Replace.
most people are not doing them at the same time. Most
Yeah.
people are doing them sort of
One or the
independent of
other.
each other. Although there are some cancers where they're integrated together, and kind of to have the effects of both. When I've done it, I've tended to do it more independently to one, have a better sense of whether it's having an effect, and two, to not have so much both side effects at the same time, risks for the patient. And so I'm tending to do it separately when I've done it.
And one of my friends, when I was in the hospital with the pleural effusion, she was doing a bunch of research, and she wanted me to ask if perhaps I should get on a different heart medicine. I'm on the amlodipine.
For your blood pressure?
Yeah.
Or for
the blood pressure, which was caused by the pills, so
yeah.
maybe I can get off the thyroid pill and the amlodipine after
I guess
this.
that's one
who
thing
knows?
too. Yeah. So I think let's see how your blood pressure does when you're off these pills, as they are probably
Right.
causing that to a degree at least, and maybe you don't need to make a change, or maybe you can even come off the blood pressure medication altogether if your blood pressure
Goes
normalizes.
back, yeah. And then Jill from church, what was that stuff, like some kind of vitamin IV infusion stuff? I don't know.
I mean, I'm a little bit skeptical about those
Yeah.
sorts of things for the most part. Most of them don't do much.
Was it vitamin D or C or
Something,
I forget.
some place in Largo that she swears by and wanted me to go visit, and I've got the brochure somewhere, but
I'm
figured I'd ask before
I'm somewhat skeptical about these things having the ability to have a major impact on people's cancer, because I think if something was really dramatic, we'd probably find out about it pretty quickly and start using it in our medical practice. I mean, I would be very happy to find something like that personally, and even though it's not a pharma drug and just a vitamin, that'd be awesome. So I just have a little bit of skepticism about it. Most of them though are not really harmful. It's just more like I just worry a little bit about the sort of I don't know.
Yeah.
Taking
Okay,
advantage
yeah.
of people
Everyone
in a
has all
desperate
kinds of
situation,
advice
sort
for
of
me, and
situation, and people spending
this
money
cures
on
cancer,
it.
and
So
AHCC mushroom stuff that my friend
Yeah.
keeps sending me, like, oh, this cures cancer. I'm like, okay.
yeah, I mean, most of them, pretty skeptical about, and but a lot of these things haven't really been tested,
Right.
So that's, I guess, the other side of it, it's not too many of these non-pharmaceutical or more, supplement type things don't really
They probably don't hurt.
often get tested that
but
much.
they probably,
Occasionally we see people have issues with taking supplements because it is a medicine like anything else. You take enough of some extract or some supplement, and I've seen somebody put themselves in liver failure from taking too much stuff. So the kind of side effects occasionally if you overdose on
Do you know what
whatever.
they were taking?
That person,
Yeah.
I probably
Make sure we don't try
he was
that.
taking a few things, like one of these handfuls of supplements, that person, but still, it's. I mean,
I'll
you
dial back
can
just
you
most
can
of my
overdose on
stuff.
almost anything, I mean, so there are some,
Yeah.
people can overdo it. Most of the time, these things are, not having a major effect on the system, but it's hard. A lot of them are hard to know. They're just not that well tested.
And especially with sarcoma too, since it's
Yeah.
so unusual.
I mean, even for more common cancers, I mean, people do. People are unfortunately, have when we don't, the medical system doesn't have great options. It makes sense to me. People are willing to try everything, and I definitely understand that. And it's just the only hesitation is sometimes sometimes it can be a bit of a false hope sort of scenario, and then so occasionally we can actually see it be harmful. So there is a little bit of a just hesitation for that reason, although
Okay, thanks. Okay.
Here's your most current scan here, just to show you, give kind of like an overview of what kind of the status is. This is the effusion here on the right lung. You can see it kind of as you lay down, it goes to the bottom mostly.
Okay.
So you can see it doesn't, take up the whole lung or even half it, but it's, moderate in size, you might say.
Right. Okay. Yeah.
It's a little bit hard to compare to a chest X-ray, and
And is it filling up just because that's the space where the lung got removed? Is it just filling up that space, basically?
Well, this is sort of the space between the lung and sort of the chest wall. So it's called the pleural space, and there's your lung kind of can shift and move as you inhale and breathe, and it's kind of a little normally very thin layer of fluid between there, just to give it less friction. And then whenever there's a disruption of that edge or a disruption in the outflow, that's when fluid can accumulate.
So is the fluid inside the lung or between the
chest and the lung, but it kind of compresses the lung because of the taking up space. And so you have less lung volume overall because of the space taken up by the fluid pushing the lung further up. So it's not really in the lung per se, it's in the lung cavity where the lung would normally fill the space.
Okay.
If that makes sense.
Mm-hmm.
To give you an idea of where. So here's an example of one of the lung tumors. It's probably the largest one. You can see it's not huge, but you can see where the normal lining, has a clear border. There's one that's sort of growing near the border of the lung there.
Okay.
It's more of this more rounded thing.
Huh.
And that's what your lung tumors would look like on a scan. We see down here, for example, a more faint, probable small tumor.
Okay.
More, you might say, inconclusive radiographically, but in light of knowing that you have these ones in the lung, this is probably a small tumor that, has developed since your last surgery. And
would this thing on my breast show up on this?
let me see about that area.
scan,
They didn't mention that actually in the report, I don't believe, but let me look to see.
Did you recently have a mammogram?
I did. This in the fall. But they wanted to have a follow-up one, but I blew it off.
So I don't see anything that's obviously conclusive here, but this is your your breastbone in the middle there, and this is on the left side. This is the right side.
So that would be
See
right
that
where
little-
it is.
This is near the area where you're kind of pointing to, where it feels like a little bit
And
thick in
it's
there,
tender, yeah.
and it feels a little tender there. There's a little bit of like sort of thickening in the soft tissue there that is not obviously as nodular, but some tumors can be a bit more diffuse, and so you could have a small. I'm not 100% sure about that area, whether that's a tumor or not. I mean, on the picture, it's not. Even the radiologist didn't really pick it up as like a clear abnormality, but you can see there is the density there is slightly higher, and closer to
I wouldn't
where-
have developed breast cancer in addition, but would I be sticking with
It would be
sarcomas or?
I think it would be more likely to be related to your sarcoma than to be something new altogether. I mean, it's stranger things have happened, I guess, than people having two cancers,
Right.
that are different. Even if it was, I think the sarcoma would still be clearly the one that's the more problem one.
And you can't see the thing on the back really either.
I'm trying to go back, to where your scar line is to see if there's anything obvious I can show you here as well. So probably, you can see normally in your,
So this
outside.
spine,
So
I
this
guess.
is your rib cage here, and the
that's my
spine
rib.
in the back. These are ribs, and so there's a little bit of muscles near the spine in the back, the thicker areas, the more dense areas, and then there's a layer of more fatty, I guess, tissue, like that's between your muscle and your skin. And that's less density, and you can see some areas that are slightly asymmetric, like up here. See that one area right there? That's a bit more, denser and a bit more nodular. And I think that could be, again, a small tumor deposit that's near the prior scar line. Things like this, when they're small like this, it's within the realm of possibility that this is just scarring from your surgery. Like this, see this more fuzzy area here that's a bit more thicker on this side, and this looks more like scar tissue, I would say. But that one
And that's the right.
that's on the right side
Okay.
of the upper back there. But see this one here that's a bit more circular, even though it's small. That could be a small tumor deposit slash,
Okay.
regrowth in the immediate area. The scans are not.
And because this was taken with me, like this isn't a view of looking at my back that way. It's
Sort of your whole body, but this is cross section.
but it's
here.
cross section. Yeah.
The way that we're looking at it.
Okay.
So I don't know. That one is, I guess, especially if you feel like kind of growing or becoming more sensitive over time. I guess that makes it more likely that it is a tumor. The small tumor regrowth in the area. But again, it's not. Sometimes when things are small, scans are hard to be conclusive on. There's some things that are more obvious than others, like the one in the lung that I showed you is pretty conclusive, I would say.
Mm-hmm.
Just given the size and the circular nature of it, it's hard to chalk that up to anything else. Even that's still on the somewhat about a centimeter. It's not huge, but it's the things on the back that I was pointing out here are pretty small.
Okay.
It's in a sensitive area because you lean back on it or you hit it, but.
Well, I definitely have a lot of scar tissue, so.
But some of that could just be scar tissue, and sometimes that in an area of surgery can be a bit tender, and the nerves don't quite reattach the right way either. So I don't think there's anything like a big tumor in the area that's growing that you can see, but it's.
Oh, that's good.
But there are these things, and some of these areas are slightly worse over time. Like the ones in the lung that I pointed out. One other area that we were tracking was the liver. At one point, I think we were concerned that could there be some small deposits in the liver. You can see this is the liver here.
Mm-hmm.
And these white areas are normal. That's like your blood vessels. But what I'm working with these more, in this case, the darker areas, like those small things there. They look a bit cystic because they're low density currently. And so even those are not conclusive, so people can have liver cysts. But sometimes tumors can look like that, as more like a shadow in the liver, show up like that.
Okay.
And so we could be seeing small things in the liver. Those are things we've been tracking since you've been on this medication. And they haven't changed recently, at least, so that's somewhat reassuring. But still, all as you're reading through your reports and seeing all the different findings, these are some of the things that to show you visually to kind of correspond to those.
Okay. All right, that was helpful. Thank you.
So,
Keep popping up everywhere.
yeah, I think unfortunately that is likely to happen over time. The
Other places that
only
they might likely.
positive, the
Metastasize
most
too?
common would be the continued pattern in similar areas to where we already know they are able to grow, like the lung. Like new areas in the lung would be the most common, most high risk area, I would say. And the only positive is, I guess I would say, is that the degree of tumor burden in the body is still pretty low, and I doubt the tumors themselves are affecting you now. It's probably more the treatments and things that we're doing to you that are affecting you than anything else. And the goal of going through all this is to try to keep it that way, to prevent these things from really affecting you.
Right.
And we do have some people that we're able to do that for multiple years with, and we've already been at it for some time.
2.5 years. For the most part.
And and sometimes we have a more pronounced effect with some of these therapies. For some reason, it's just a bit more sensitive than others, and can really buy a more significant chunk of time or go through a round and then take a break because it works so well. So I think we should move on to the next one, see how well it works, and then pick out our options based on that. So
Okay.
you can stop taking the pill.
All right. I feel like I need to sell it on the black market as expensive as they are.
Yeah, seriously, yeah. Don't reorder them anymore.
At least
I
I
guess
dropped $12,000 to $6,000 and they switched to the generic, but still.
Those are pretty crazy. I love the economics of this. Hang out for a minute so we can do some of the paperwork and stuff and give you some information about the chemotherapy you guys can look up and things.
Okay.
When Holly will come back and do some of that with you.
Okay.
All right.
Thank you.
You're welcome.
Thanks.